mean, this sentence, I think it's a worldwide accepted sentence. Two-stage implantology is a proven evidence-based method of treatment and it works. I think this is what Professor Natsch was going to tell us, or tried to tell us. Now, the first problem with all these statistics is that these statistics include only treated patients. It does not include patients which were not accepted for treatment, and this intent to treat principle, which is a worldwide accepted principle for medical statistics, is violated in every scientific study in dental implantology. Because this intent to treat principle requests that all patients who seek the treatment have to enter the statistics regardless if we treat them or not. We may keep them in separate sections why we didn't treat them. Maybe it was financial reason, maybe it was a medical reason, whatever. But we have to look at the whole population and we have to include into our statistics all patients who seek the treatment. This is a worldwide standard. Of course, it's true also in other disciplines working with the bone, like in traumatology, in orthopedic surgery. Because in these fields, the practitioners cannot turn away the patient. Only we can turn away the patient. We tell them, you don't have enough bone. It's too difficult. We're not going to treat you. This option, of course, is not given for the orthopedic surgeon. If the patient with a broken arm or the broken leg or with a polytraumatic motorbike driver turns up in an ambulance, it's not possible to tell him, look, it's too difficult, we are not going to treat you. So, ladies and gentlemen, this intent to treat principle that every patient who enters the door into our office and requests treatment is very, very important. It's a question of humanity to work on the basis of this principle. So statistics only include treated patients. It does not include patients which were frightened off by a joint operation, by bone transplant, and who simply could not afford this treatment, or who could not afford, for example, reasons in the family or reasons in the office, they could not afford to be without teeth so long, and they could not afford to be away from the job so long. The third problem which we face in dental implantology is the wide variation of success rates. I mean, you should think we are doing this now for 20, 30 years, so we should have a very, very high success rate. This should be predictable now to stage implantology. But in fact, it's not. Always you see statistics which come up with low figures, in bone after radiation, which come out with low figures in bone after chemotherapy. So the success rates, of course, are to be doubted. The next problem is that the statistics stem mainly from government or university clinics who typically exclude all risk groups. Now, if you look at the articles, for example, of the Bern School, I mean, this is the worst. They are excluding everything that simply looks a little bit like a problem. And again, the intent to treat principle requests from us that we try to provide a treatment to everybody. So everybody who walks into the door and requests dental implants should get treatment. Now let's look at the treated patients. What happens to them after they have this two-stage treatment? Now looking into the topics of congresses which I attend, I can see that a lot of people are worried about peri-implantitis. Now, peri-implantitis occurs in between 6 and 58% of the conventional two-stage implants. And the chances of successful treatments of this peri-implantitis are 0. So this is the sad reality, and this is not really talked about on the congresses in this clearness. So I want to remind you that even if your implant is going to be a success, more than half of your patients are likely to run into a periimplantitis. And this is they carry this problem on all their life until you take the implant out. And of course there are treatment alternatives who definitely are without periimplantitis. Now this picture, I took this picture from the Swiss Schweizerische Monatsschrift für Zahnmedizin, so from the journal of the Swiss dentists, the official journal, and it shows here 100% successful treatment because there is no mobility and there is no pain. And of course this comment must be questioned. What we can learn, however, from this picture, from the worst things we can learn something, but what I recommend that you learn from this picture is that although there is a profound periimplantitis, the implant in fact is stable. But where is it also integrated? It is integrated in the basal bone. So all the rest of the bone, all the bone parts which come and go with the teeth, or which are more than likely to go when the teeth are leaving, all these bone parts are in the discipline of basal osseointegration not necessary, and it would not have been necessary that so much vertebral bone around this rough surfaced implant is lost. The next problem, I think I skipped the problem, but the next problem is of course how the success rates are measured. The success rates and success times are in most publications counted after implant integration, which means it is counted after the prosthetic phase starts. And if we consider the intent to treat principle, then we have to count differently. For example, if we do a sinus lift, which was intended for the later placement of 3 implants, and if this sinus lift fails, then we have to put those 3 implants as a failure into our statistics, although they have never been placed. We have to do this if we are honest. And I have never seen such a publication. A publication which is mentioning non-placed implants as a failure because of bone augmentation from powder or from block transplant and so on, because this has failed. Now remember please the intent to treat principle. We have to obey this principle if we want to give honest answers to our patients. And I'm coming back now to the picture which I've shown you earlier in this lecture. So typically in science we have a lot of facts, we have mesio-facts and we have theories. And I think very often in dental implantology we have this. We work without facts, there are a few mesio-facts, and there are so many theories. And the theories are, I can tell you, I'm traveling around the world, lecturing, listening, discussing, treating. The theories are enormous. So don't believe that what you think is the valid theory in Hungary is believed by anybody else in the world. So there's a lot of influence by local givers of ideas. Now let's come to the implantology.